welcome everyone to the Iridex booth and our speakers forum. I'm Joan Stauffer, Product Marketing Director at Iridex for Retina, and it's my pleasure to welcome to our podium Dr. Orr from the Ohio State University, who's here to present on advanced imaging after MicroPulse laser. And thank you, and the podium is all yours.
Great. Thanks, Joan. My pleasure to be here as well. So I'm just going to talk to you a bit about some advanced imaging after MicroPulse laser, and start out with my disclosures. So just a little bit of background with MicroPulse and to kind of get everyone on the same page. MicroPulse, we know for diabetic macular edema is a treatment, and we know that for diabetic macular edema, it's the #1 cause of vision loss in eyes that have diabetic retinopathy. And so we all know that diabetes, prevalence in the US is 7%, and 21 million of the 300 million people in the US have diabetes. So the prevalence in US diabetics is about 30% in patients who have had diabetes for 20 years or more. And untreated patients with diabetic macular edema will experience doubling of the visual angle over 3 years. So the options that exist for today for diabetic macular edema are focal laser and intravitreal injections, and anti-VEGF and steroid are known treatments. And today we're specifically going to be talking about the focal laser options. So historically for focal laser, we know that the goals of doing focal laser is to decrease the risk of moderate visual loss or doubling of the visual angle by 50% over 3 years, and that's the historic focal laser treatment. So how does this work? Well, with photocoagulation, the goal is destruction of the photoreceptor layer, and the idea is that by doing this, you would improve retinal oxygenation, reduce metabolic activity, inhibit angiogenic stimulators, and increase anti-angiogenic factors. When you treat with photocoagulation, classically, the temperature rises from baseline and spreads toward the choroid and neurosensory retina with temperatures that can reach +20 to +30 degrees Celsius. There's a zone of latent lethal damage that's created which may spread and decay. And so when most of us think of focal laser historically, this is what we think about, okay? Focal laser with a visible endpoint. And we know that when you treat with focal, historically, this is what patients look like after treatment. Of course, this is the one thing none of us want to see, which is focal laser treatment that ends up in the center of the macula, which is always a concern with focal laser. And again, just other imaging that shows this damage that can occur. So that brings us to the current discussion of what is MicroPulse. And so MicroPulse has a lot of names, and you'll see MicroPulse referenced a lot of different ways. MicroPulse diode laser, MPL, is one way you may see it described. Subthreshold diode laser, MicroPulse photocoagulation, or simply subthreshold laser. And the most important point with all of this is the idea of threshold. And so when you think about focal laser itself is really a threshold concept, right? So photocoagulation of the peripheral retina is that standard white burn that we see for an endpoint. Focal laser in its infancy was the idea that what if we could turn down some of the effect of the laser and still get an endpoint with it. Now threshold itself as a descriptive term has seen an evolution as well. So it's no longer just can we turn the power down and can we see that there are less visible endpoints like a lighter burn for instance, but can we still get clinical effect without the damage that we see with traditional focal laser? The details of MicroPulse as it's described, and this is a concept that I think is worth thinking about, is the idea that what if we take a continuous wave and we chop it into small pulses? And if we deliver those pulses in a different way than traditional laser. So when we think about continuous wave traditional laser, this is what we think about. So it's a beam, you push the pedal down, the beam is delivered continuously, and then the beam stops. Focal laser then, MicroPulse focal laser cuts that beam into very, very, very small envelopes of treatment so that the laser is not truly on the entire time. And then actually most of the time, depending on your duty cycle, the laser itself is off. So you get these very small segments of treatment that are dosed accordingly. So the idea is that repetitive short pulses permit the tissue to cool between the pulses and prevent that thermal buildup, and consequently, hopefully, prevent the damage that you see. So again, if you look at this heat model of traditional constant wave treatment, if you look at the top bar, the gray bar there, which represents that continuous wave, what you'll notice is the heat thermal temperature raises quite quickly and stays elevated and has a prolonged cooling phase. MicroPulse is different in that you never reach that same threshold of temperature. In fact, these small pulses only allow small buildups with a long time to cool down, thereby hopefully preventing the damage that you might see with traditional laser. So the first question is, does it work? And so there have been numerous studies, and this was one of the earlier studies described by Luttrell et al., which described that subthreshold diode micropulse laser for clinically significant diabetic macular edema had a beneficial effect on both vision and the clinically significant diabetic macular edema. Well, how does it compare to the standard treatment that we have out there? Well, standard treatment being mEDTRS or modified mEDTRS treatment was looked at, and this is a study that was shown in 2011 by Levinsky et al., and they described a randomized clinical trial evaluating just that, modified mEDTRS versus normal or high-density MicroPulse for diabetic macular edema. And they showed that it was superior to conventional modified mEDTRS photocoagulation in both reducing the thickness of the macula and improving the visual acuity in diabetic macular edema. Now, I will say, obviously there's a lot of studies that are out there. A lot of these trials are smaller trials, so I think we're still learning about the effects of that. But the trials that you see out there, a lot of them do reference these, and I think there are, like I said, a lot of other shorter trials that are in there as well that are very reassuring. So that takes us to our current case presentation and what I wanted to talk to you about in terms of the advanced imaging. So this is a 41-year-old male presented to me with a 25-year history of type 1 diabetes. He's a very active guy, very nice guy, and he presented for a spot which he noticed in his right eye, and he described as up and towards his nose. So when we did the initial imaging on him, you can see this is a fundus photograph of the right and left eye, and in his right eye in particular, draw your attention to this area here, where there appears to be a little edema that you can see even on the photograph. We did OCT imaging, and on the OCT, again, draw your attention to this area, which is the area of edema that we saw for him. Comparatively, in his macular change analysis, from the last visit to this visit, there had been a significant increase in the amount of edema that was in his retina at this point. On OCT, on the raster scan, again, you can see where this edema is represented here. So when we focus down on this area of edema, this is where all of the action was for him. So we, of course, did fluorescein angiography to see what this looked like, and you'll see, especially in the late phase here, some leakage around that area, some microaneurysms that are scattered about. And for me, at least starting out, we've had the Iridex laser now with the MicroPulse technology for about 2 years at our institution. And so one of the things that I kind of looked for when I was first starting out with MicroPulse are who are the patients I'm going to treat, right? So, you know, we have anti-VEGF therapy, we know that works for center involving edema, and we also know, and at least the way I practice is, we treat a lot of focal laser for patients that have edema outside of the macula, because, you know, those are the patients who tend to benefit the most from focal laser without the concern for the vision changes. So these are prime candidates for MicroPulse, at least for when I was starting out, because I felt like we can try that treatment and see how it does. And again, we have other standard treatments that we can use if it didn't work. So this type of patient is the ideal patient for what I was looking for when I started using MicroPulse technology. So my settings are as follows. These are very, very conservative settings. That's one of the things I'd urge you when you're looking at that is to pay attention to the settings, because there's a lot of different studies. There are different lasers that are being looked at, different wavelengths, and you want to pay attention to that. But these settings are very conservative. 200 micron spot size, a 7x7 grid with no spacing, a 200 microsecond duration with 400 milliwatts, and a 5% duty cycle. And the reason that I like this particular setting is it's never been shown to cause any damage in any patients. So it's a very, very conservative treatment. So again, the way that I treated this patient is with a confluent laser that looks just like this, 7x7 grid. Now, in full disclosure, currently now, I treat with a more aggressive treatment. I would actually probably use at least 4 of those same grids. But when I was first starting out, this is the treatment I used for him. So 3 months later, this is what he looked like. So again, starting before treatment and after treatment. And what you'll notice right away is the edema already looks better. Some of the hemorrhages are improved, the microaneurysms are improved. And again, from the OCT, you see what he looked like before, and now what he looks like afterward, with the edema improving significantly. This is the OCT, and the OCT orientation is a little funny, so I use an arrow just to kind of point out. Again, this is the inner and outer retinal changes we noticed before treatment. And then if you look at the arrow, it inverts, so the other side is actually where the edema was previously. And you'll see that the inner and outer retinal changes have resolved. So he did very well, and it got me kind of interested in terms of what we know about treatment and kind of what we see after treatment. And so there have been trials that have looked at the changes after MicroPulse versus modified focal laser. This is a trial by Vujosevec et al. And I think you see this data around. But basically what they looked at is what does the modified mEDTRS do to microperimetry and as well as the changes you see in fundus autofluorescence. And you'll see here that the microperimetry decreased after treatment with modified mEDTRS, but the fundus autofluorescence had increased signal for even up to 9 months afterwards. And you can see those changes reflected here, all those hyperreflective spots on autofluorescence representing the laser treatment. So with MicroPulse, the microperimetry actually showed an increased retinal sensitivity, but the fundus autofluorescent remained stable, so there were no changes that could be recorded or documented. Again, these trials have been done looking at yellow and infrared laser, and again, another trial that was done, it showed no visible scars by photography, fundus autofluorescence, IVFA, or SD-OCT. So we happen to have at our institution an adaptive optics instrument, and adaptive optics is a bit of a newer technology, but the principle behind adaptive optics is it uses active optical elements basically to compensate for optical aberrations. So the idea is, how much detail can we actually see in the retina when we're limited by these optical aberrations? Adaptive optics compensates for that and allows us to see direct visualizations of the individual cone and rod photoreceptors, as well as RPE cells and white blood cells, et cetera, et cetera. So we thought it would be interesting to see what we saw with MicroPulse with this. And so just as kind of an example of what adaptive optics looks like, it's a little bit of a busy slide. The 2 blocks at the bottom are what adaptive optics shows. It shows the individual cone and rod photoreceptors, and you can see some blood vessels there. The image in the middle is sort of the larger view and where the boxes are coming from. And then of course it's on the background of a photograph and an OCT at the top, just to kind of show the capabilities of adaptive optics. So we do know that with regular focal laser, we've been able to show the changes that take place. So after focal laser, if you look at OCT, there are clear indications that treatment's been done. Okay, you get changes in the outer retina, hyperreflective changes that show where the laser treatment has been done. Adaptive optics has also looked at this, and it's the same thing. When we look at adaptive optics after focal laser, what you'll notice is a complete loss of that photoreceptor mosaic in the region where the treatment was done. So in our particular patient, we looked at where we had done that laser. And when we zoomed in, one of the things we noticed was kind of interesting is before treatment in this area, and you'll see here with this blue arrow, that the photoreceptor mosaic was very difficult to appreciate. In fact, it was very blurred. And so this was the area where the edema was, and clearly that would have an impact on what we were able to visualize in the retina with that. So before treatment, this is what we noted. And after treatment, what you'll see is the mosaic improves quite a bit. It's not quite projecting as well on the screen, but the individual photoreceptors are a lot clearer to see. And the impact of the laser, which was the most important finding from our side, there was no loss of photoreceptors. There was no change to the mosaic or decrease in the rods and cones in that area. In fact, they became clearer and much easier to visualize after the edema had resolved, which we thought was kind of interesting and hadn't been described before. And again, this is just a larger version of that same image. So in conclusion, adaptive optics showed no damage to the individual photoreceptors following MicroPulse laser, and this is just further evidence that suggests that MicroPulse laser is a safe and effective treatment for diabetic macular edema. I'd like to thank my adaptive optics team. and I would welcome any questions. Put my headset on here.
Thank you very much. And we have a question. Can you hear me okay? Thank you.
Can you go ahead treat the fovea in the same?
So people have described treating through the fovea.
Right.
I have not yet done that intentionally, but there's a lot of description about people doing that. I think with these settings, you'd be pretty safe to do that, but like I said, there are people that describe that. I myself do not yet do that.
Okay. Can you show us the slide again so that we can take a picture of it?
The settings?
Settings.
Yes. Are there any other questions while we're...
Do you think now you are going to stop injections?
No, absolutely not. I think anti-VEGF is still first-line treatment. The question, and the interesting question about this would be, how does this work in conjunction with anti-VEGF? So those studies are yet to be done, and that's the stuff that I think is the most interesting. Can we reduce treatment burden with MicroPulse, and how does that work?
Hi. I'm just asking about the setting. Is it the same setting for all the swelling, regardless of the thickness of the macula? So if you are treating, like for example, 450 central from the macula.
That's a great question, and so the answer for me personally is yes. These are the settings that I use. There's a lot of different descriptions of settings that have been used when you look through the literature. The most important, of course, is duty cycle. As far as I'm concerned, you have to pay attention to that because people will use higher duty cycles, and I think you have to be careful about that. And there's some subthreshold descriptors that are mentioned in the literature where they actually see an endpoint, and I think that's also something that needs to be teased out. So I think it's a great question that we just don't know the answer to. It seems that especially at the 5% duty cycle, there's a pretty large safety buffer for that. And so you have a lot of flexibility, and I know people describe, treating to a visible endpoint and then cutting that power in half or a third. Right, so there's a variety of ways that you can approach that, I think.
Another question, actually. Is it, in your experience, affecting the visual field? Have you done like visual field assessment for patient with...
I have not,
No.
but it's a great question.
But when you show actually the photoreceptors, which looks like intact, that's quite interesting to know actually about it. And even other question also. Do you treat all the swelling on the macula regardless? Is it clinically significant macular edema or not, or usually? Because
it's a good question. I mean, in general, we try to focus on the clinically significant diabetic macular edema, but I mean, there's of course patient considerations to take into consideration with that. Yeah.
Thank you.
Suppose you have a patient where there is macular edema. How are you going to treat that?
So you mean central macular edema?
Central.
Yeah. So I mean, my first line would still be anti-VEGF treatment. I mean,
Okay.
that would still be my first line of treatment.
Suppose patient is not responding.
Right. Well, there's two parts to that, so that's a great question. But and I want to clarify the first thing I said. So let's say the patient's visual acuity is 20/60. They have clear change in vision.
Right.
Anti-VEGF is going to be my first line.
Right.
An interesting question is, what if they're 20/20? That might not be a patient that injections would be the first one to start with, and you might consider focal, MicroPulse focal for that. But again, these are questions we don't have answers to, but they're good questions.
But would you spare, if you're treating the central area,
Right.
you'd spare the fovea?
So what I do personally is I put that square grid, that 7x7 grid, around the fovea. So I would, basically put 4 blocks where that swelling was and spare the fovea. But again, people have described treatment with no change in vision, and again, these, this is still a bit of early technology as far as the literature is concerned, as far as I'm concerned. And when we got the treatment, what I wanted to make sure was, first I need to prove to myself it's working, I need to prove to myself that it's safe, and that's what the point of doing some of these things has been, is to say, okay, I feel like it obviously worked for this patient, it was safe, there were no changes there. Would I be comfortable treating to the fovea? Like I said, there are people that do that classically. I personally am still a little bit slow to move into that area. We'll see.
Do you have any pictures of the area of treatment or the fovea?
I don't.
And how long would you wait before you see any changes after the laser that it has worked? What's the timeline?
So I still go by the 3-month effect treatment that we use for standard focal in terms of waiting for the focal treatment to change. But of course that's a variable target as well, because if they come in and their vision's getting worse and the edema is getting worse, I'm not going to wait 3 months to inject or do something different. That would be patient dependent.
And would you retreat with this laser again after 3 months or so if it doesn't work?
I think it's worth considering, absolutely.
Gotcha. Thank you.
On your patient, doctor, with the adaptive optics, what was the visual acuity before and then after in
2020.
Okay, both on 2020. So that swelling went down, no photoreceptors, rods, cones, or anything were damaged, and you were still able to maintain the 20/20 vision.
Correct.
How many other patients have you imaged with this technology, and what are you seeing? Or
my basic science researchers are going to kill me. We have about 4 right now that we're looking at.
Okay. Any other questions? Okay, well, thank you very much. Thank you for attending.